Okay, hello everyone. Thank you for joining us today. I am Erica Hurdle. I'm Program Manager with the Iowa Regional Autism Assistance Program, and I'm here with Dr. Kelly Pelzel. Dr. Pelzel is a licensed psychologist and a clinical assistant professor working in University of Iowa Stead Family Children's Hospital's Adolescent and Child Psychiatry Division. She received her BA from the University of Northern Iowa and her PhD from the University of Utah. Dr. Pelzel provides assessment and treatment services for children and adolescents. She also is involved with intervention research. Additionally, Dr. Pelzel is a psychology technical consultant for the Iowa Regional Autism Assistance Program and clinical coordinator for the University of Iowa Stead Family Children's Hospital Autism Center. Dr. Pelzel is interested in evidence-based therapies for young children with and without autism. And now I will turn it over to you, Dr. Pelzel.
Thanks again, Erica, for that introduction, and welcome back. We're going to be talking a little bit today more about intervention. So last week we talked about all kinds of interventions, but I left out information on treating dangerous or destructive behavior because this is something I wanted to devote some additional time to. And so we're going to first just learn about kind of what is dangerous and destructive behavior. Why are we spending this extra time on it? Before I talk about two different kind of approaches to treating this type of behavior. One is more based in ABA, applied behavior analysis, and takes into account what they think is the function of a behavior, or kind of what maintains the behavior over time. The other approach I'm going to talk about is parent-child interaction therapy, which is still a behavioral approach, but is more standardized and doesn't really take into account in an individualized way the function of behavior the way that some of the other ABA approaches do. And then we'll end talking a little bit about eating concerns and treatments for those, because that was something I also didn't have the opportunity to cover last time. And Erica had mentioned I do intervention research, and actually it is on some of these function-based approaches. And so just to note that I have that as a bias. I also offer PCIT, parent-child interaction therapy, as a clinical service, both to young kids with and without autism and their families. So, you know, from last week that I do have this bias towards interventions that have lots of research behind them. And this is one of those situations where you have some choices, because both these functional approaches and those that don't take function into account so much have research behind them, and I like them both. So I do research on one and offer the other clinically. Okay. So I've called this presentation many things over the years. Call it challenging behavior or disruptive behavior, but I've really been thinking a lot about language and trying to be sensitive to all that, and really tried to be better at defining what I actually mean by challenging or disruptive. And what I mean is behavior that we would consider dangerous or destructive behavior. So certainly there's other behaviors out there that could be problematic to some people. But they're not things that are where someone's going to get hurt or something's going to get broken. These are the kind of behaviors I think that we have pretty good agreement across folks that these things would need to be addressed, because we don't want people to get hurt. We don't want things to get broken. So we think about things like aggression, like hitting, biting, those sorts of things, self-injury, like head banging, or kids who gouge at their eyes or bite themselves, destructive behavior, breaking items, throwing items, or severe noncompliance. Again, that causes like some safety concerns, like kids who may elope from a place when they're not wanting to do something. So again, these are behaviors that result in harm to self, others, or the environment, and interfere with daily functioning in one or more settings. We would not be looking at any sort of behaviors with these things that are the behavioral symptoms of autism, like repetitive behaviors or something like that. That is not what we're talking about here. And we're focused on this because these kinds of disruptive behaviors, these dangerous and destructive behaviors, are observed at a substantially higher rate among children with autism than typically developing children. And what we know is that these behaviors are correlated with increased stress for parents and families and caregivers. And when that happens, you get kind of a nasty cycle going on, because when you're stressed out as a parent, that really disrupts you being able to effectively parent. And when you're not effectively parenting, that's going to exacerbate the child problem behavior. So you get kind of stuck in this loop of this stressed out parent and child that has some significant behavior issues. And so the other thing about it is that when kids have significant behavior like this, challenging behavior that's destructive or dangerous, oftentimes they can't participate in skill building interventions, like some of the interventions I talked about last week, until we get the dangerous and destructive behavior kind of handled appropriately, treated first. And so it does create this disparity in access to treatment for these kids that have dangerous and destructive behavior. There's a few different treatment options. I wish there were more, but these are the things that we know work well. Behavior therapy, which is what I'm going to be talking about today. Actually, parent training I'm going to be talking about today as well. I cited a specific training program, but actually the approaches that that I like here at Iowa you typically do involve parents being a part of the therapy. And then the third option is medication. When we think about what doesn't work, what we know doesn't work, there's very little evidence for insight-oriented therapies, so like a talk therapy or a traditional play therapy, reducing dangerous or destructive behaviors in youth with autism. So we're talking about different kind of intervention here. Okay, I'm gonna talk about medications first and kind of get that out of the way. Again, I'm not a medical doctor, I'm a PhD. But these are the medications you oftentimes see used with autistic individuals who have co-occurring challenging behaviors, like dangerous or destructive behavior, ADHD behaviors, anxiety, depression. Risperidol and Abilify are often effective for treating irritability, aggression, and self-injurious behavior. It does have a side effect oftentimes of weight gain, so people look at that pretty closely. Methylphenidate stimulant medications are effective for ADHD symptoms, and oftentimes they use other medications as well, either with or without stimulants. So things like guanfacine, clonidine, and Strattera are often also used. And then fluoxetine may be effective for anxiety or depression. So if you think about, sometimes those dangerous destructive behaviors are kind of being triggered by high anxiety. And in that case, fluoxetine may actually help with the behavior as well if there's anxiety present. But now let's turn and talk about behavior therapy. And like I said a couple of slides ago, you can think about providing behavior therapy directly to a child. So a provider or an educator working directly with the child. Or you can also think about teaching and coaching a parent or other caregiver on how to do the intervention. And sometimes that's called parent-mediated interventions or parent training. But the idea behind it is that caregivers really, they know their child. We know a lot about the intervention and child development, that sort of thing. They know their child. So they can think about how to apply what we know and individualize it to their child. When we teach things to parents and other caregivers, we're really increasing the amount of intervention a kid is getting across the week. And it's also a way to allow for greater generalization outside of the therapy room, outside the clinic office. So for those reasons, I've really gravitated towards parent-mediated interventions. And the ones I'm going to be talking about today are ones that typically are done in a parent-mediated fashion, or at least involve parents and train parents in these ideas. And right, so here's just the same idea, but more visual here. So we're talking about interventions that use behavioral principles here. We have a parent involved. There's some sort of destructive or dangerous behavior we're treating. And then our treatment plan, this is kind of where we're going to go here with these next few slides. Our treatment plan oftentimes is based on the function of the child's behavior or what's maintaining the behavior over time. So with that, we're thinking about what comes before a behavior, the antecedent, the behavior itself, and then what comes afterwards, what follows the behavior, the consequence. You may remember these ABCs from Psychology 101 course. It's kind of at the heart of a lot of behavioral approaches. So just a word about those antecedent strategies. These are things we're doing to try to reduce the likelihood that the behavior is going to occur. If it's a dangerous or destructive behavior, or if we're thinking about increasing an appropriate behavior, that we're putting things in place to increase appropriate behavior. But things like transition cues are a good example of an antecedent strategy, letting a child know that we're going to be ending one thing and moving on to another. You may remember last week from the video with the child showing structured teaching, the TEACH program. They use a lot of visual reminders to help the child transition, help provide those cues. But there's other things too, like verbal prompts, like, hey, in 2 minutes, we're going to pack this up and do something else. Or timers that go off, buzzers, music. The cleanup song is an example of a transition cue. Nonverbal cues like moving towards the door or letting the child know it's time to clean up through gesture. So those are all things kind of on the antecedent end that people might consider in terms of transition cues. And then on the consequence side of things, we're typically thinking about rewards and punishments, reinforcers or punishers. And we tend to focus more on reinforcers because they work better. And so we think about what we want to do to try to increase the frequency of a desirable behavior. And we can do that in a couple different ways. One is to add something on as a consequence. And then another way is to take something away. Take away something that is maybe a negative, a stimulus that would not be very much fun. So let me just give an example here. And this is a real life example. My son has been having a hard time getting his piano practice in during the week. And so we were thinking last night about how to set up a little reward system for him. And so we're going to go with like a positive reinforcement system where when he practices, which is the desirable behavior for us, we're going to allow him a little extra time looking at stuff on YouTube, right? That's going to be the positive reinforcement, is he's going to earn some more YouTube time by practicing the piano, the desirable behavior. Now we could have set up like a negative reinforcement system, and that would be where we would maybe take something away that he doesn't like to do if he practices the piano. So for example, if he practiced the piano, then he would have one less chore that he had to do in the evening. That would be an example of like a negative reinforcement system. That's not what we went with, but that's another reinforcement system we could have used. So these are the kinds of things people are thinking about. Again, they usually try reinforcement systems before they move to punishment systems. And certainly decades and decades of behavioral research supports the idea that reinforcers are the better bet for changing behavior in most cases. Okay. So when we start to think about setting this kind of thing up, we want to do an assessment if we're taking this kind of functional approach, where we're going to try to take a look at those antecedent and behavior, or antecedent, what's happening before the behavior, the antecedents, as well as what's happening after the behavior to reinforce it. And this can be done through two different methods, indirectly, which is kind of like talking about it, or maybe collecting a little data on it, versus looking at it directly. So a lot of times we start out with these indirect methods because they're a lot less time consuming and a lot less expensive. Also, sometimes we're really worried about a certain kind of behavior, but it's a pretty rare behavior, you know? So when it happens, it's a big deal, but we could watch for hours and hours and we maybe never see it because it only happens, you know, once or twice a month or something, right? And so things that are difficult to assess through direct observation, we also use indirect methods to get information about them. Of course, as we've talked about in this webinar series, people are not always great at remembering things. So that's one drawback. And, you know, sometimes when we ask people questions, they're not quite understanding, or, you know, they're not quite reporting on what we want them to report on. And so then we get less useful information or less useful data. But we usually start out here. And then if that is not enough information, or that's not going well, just using indirect methods, then we might move to something more direct and actually observe the behavior in action. And kind of the Cadillac version of this is called a standard functional analysis, where a behavioral interventionist would test and observe kind of one by one different antecedents and consequences of a behavior to figure out what's making this behavior start and what's making it continue. Oftentimes they're looking at behavior being maintained by three different what they call social functions. And this just means things that can kind of be controlled in the environment. So things like attention from others, tangible, meaning actual things that people want, and escape, which means, you know, a demand is presented and the behavior, you know, is to try to get out of that demand. On occasion, if they cannot kind of figure out through the standard function analysis what's initiating and maintaining a behavior, then they may also consider a behavior to be non-social or automatic, something that's kind of internally rewarding to a person that you can't really manipulate with these external social things. So yeah, they just kind of set it up almost like an allergy test, where they try out different things and see when the child reacts and when they don't, to these different situations where attention is diverted or demand is placed on them, or they remove something cool the child's playing with. What's triggering those behaviors, what's maintaining those behaviors over time. And when they do that, they oftentimes even chart out to say, like, hey, as we're manipulating these things over and over again, are we seeing any patterns? So this is a graph where they are looking at some problem behavior that's looks like destruction of property, aggression, and self-injurious behavior. So all of those things count as problem behavior on this chart. And they're looking to see across sessions, which means actually in this case, it means little 5-minute segments, how many times they're seeing those behaviors during these different conditions they've set up. And you can see here, a little pattern starts to emerge, where for this particular child, you see a higher rate of these problem behaviors when demands are presented. So then they hypothesize that it's an escape maintain behavior, and that we can use certain strategies to treat that behavior. So from these standard functional analyses, they take a long time to do, okay? But what happens then is that the interventionist can develop a very, very targeted treatment plan. It's really lean. There's nothing really in it that would be like extra information you wouldn't really need to know to treat this behavior. And with that, then the idea is your treatment can be a lot shorter because you're just focusing on the specific functions. There's no extras. So for example, for a child that does not have attention maintained behavior, you're not going to spend a lot of time talking to a parent about selective attention and planned ignoring, because that's not really a part of their problem behavior. Whereas in other interventions that don't take this functional approach, you may cover some things that are actually not that useful to you in treating the child's behavior. So it takes a while in terms of the assessment. You have to put in some extra time up front, but then the idea is the treatment is really, really efficient. And one treatment that oftentimes pairs with these functional assessments or functional analyses is called functional communication training. And that's particularly true if the child does have language deficits, communication deficits, functional communication deficit. So they're having a hard time communicating appropriately for their wants and needs. And so when we look across the different function-based treatments, basically, functional communication training has been researched the most and has the most evidence of being useful and working well. So I'm just going to kind of run through just kind of a real sketch of some of the things they may consider for these different functions of behavior, things that might go into the treatment plan. So if they've done one of these functional analyses and it looks like there's an attention function, so that the child's, engaging in this destructive or dangerous behavior to garner attention from others. What they're going to teach and coach to the parent is to really minimize that attention for challenging behavior, and provide a lot of upfront information about what the expectations are, and to really end the interaction when those behaviors occur. At the same time, we're going to really work on increasing attention for behaviors that are appropriate behaviors through labeled praise and other ways to let the child know that you're interested in and liking what they're doing. If we think a behavior is maintained by something tangible, by an actual item or items, we want to try to set up systems in the treatment plan where the child's having to demonstrate some compliance or some appropriate communication before getting access to that item. And we'll also have to set up a system to let the child know when that thing is going to be available. Because some things are not even available, even when you're being appropriate. They're just not available at that time. And so we need to be able to communicate that to the child as well. And we also are going to teach the child how to communicate to access that item. And finally, we think it's an escape function. This is when a child's engaging in some dangerous destructive behavior to escape or avoid something they don't want to work on. We want to make sure, first of all, that the thing that we've asked them to work on is something that they can do, that it's an appropriate task. And if it's within their skill range, then we'll think about like adding in breaks. We'll add in some first thens, directions. And we'll also work on the child being able to appropriately request a break. Now, over time, we're going to be communicating to a child how much they have to do to get that break. But at first, we're just going to get them appropriately requesting for breaks. We're also going to start to sprinkle in things that are easier along with things that are the newer, harder materials or demands. And we think really, really carefully in these situations about whether it would make sense to use a timeout, because sometimes for some kids, timeout, giving them that break from the demand can reinforce that problem behavior. So we think real carefully about that in this situation. Here's just an example of kind of a if-then, like I was just talking about with those demands. And you can see this child is pretty far along on their antecedent strategy here of having this visual with it, right? Because they have like 2, 3, 7. Yeah, they have 7 things on their morning routine that they need to do in order to earn their Candyland. So this is a kind of a more complex if-then chart that you would use as an antecedent strategy in the case of a child with an escape-maintain behavior. And then there's all kinds of different communication systems or ways that we go about doing communication training or functional communication training. But the idea is that we want to differentially reinforce. So we want to teach a child something that they can communicate that people would recognize as a communication. And then be able to reward them for using that communication system. And we do not want to reward those dangerous and destructive behaviors. So when those occur, we are not going to be giving a break, for example. Here's some more things, although some of these are a little bit dated in terms of pictures. A lot of things have moved on to tablets like iPads and such. Although we still oftentimes use things that are a little more simple, like there in the middle, you'll see that big yellow button that's called a Big Mac switch. And oftentimes we use that for children with limited communication skills because it's a pretty easy one to start with and for them to be able to catch on in terms of being able to tap that button. And then there's a voice activated or there's a recording of a voice on there that says the word of the thing that they are requesting. So it looks like maybe this child really likes fans, right? So they can request for a fan or to turn the fan on. Okay, so I want to show a little bit of this in action now. This actually isn't a child with an escape function. This is a child with tangibly maintained behavior. So a child that shows some dangerous or destructive behavior. I think both actually, because they want some things. And the mom is going to be talking a little bit about her experiences in treatment, and they'll show a little bit of the treatment for this child.
I want to play. Functional communication training. Tangible.
Prior to learning skills on how to respond to Cameron's behavior, we would have a child that had bruises all across his forehead because he would just get frustrated with wanting a toy and scream at the top of his lungs and headbang the floor. As a parent, it's very difficult not to give in because you don't want your child harming themselves. But it's very important to not respond to that bad behavior, because whether you respond good or bad, that just gives them more motivation to continue communicating that way. Use a communication device or PECs, and that's going to help you tremendously. There were some times when I wondered if my child could ever communicate with me. I didn't know if it was even in him. But after giving him more structure and forcing him to communicate that way, we've both developed a habit of using either a PECS card or a communication device. And you will be amazed at how much your child actually knows if you follow through with this.
FCT for a toy. FCT is often used to teach a child how to ask for a favorite toy or a favorite activity. Here are the steps to implementing FCT. A behavior assessment found that one reason Cameron engaged in problem behaviors was to get his favorite toys or other items. 4 steps were used to teach Cameron to use a communication system instead of his problem behaviors. You will use the same steps at home. First, let your child pick a toy. Have a toy or activity your child wants to play with. Your child may want to change the toy or activity during the session. You will want to notice if your child seems bored or doesn't want the toy. If this happens, offer a new toy or activity. It's common for children to want to change toys after playing with one for a while. Second, let your child play with the toy for about 2 minutes. When you play with your child, don't take away the toy or ask him to do something with the toy. You shouldn't tell your child how to play or what to do. Instead, just have fun with your child while playing. You can talk about what your child is doing by talking about the toy or naming your child's actions. Third, tell your child it's now your turn to play with the toy after 2 minutes of play. You may say, "It's my turn to play with it," or "I want to show you something with the toy." Fourth, ask if your child wants the toy back, and tell your child how to ask for the toy. If your child does show problem behaviors, stay calm. Don't talk about the behavior. Instead, remind your child about what he needs to do. Look for signs that your child is ready to communicate and wants the toy, such as reaching for or looking at the toy. Tell your child what he or she needs to do to get the toy. You may say, "Do you want your toy?" Say, "Play please," to get it. You may say, "If you want your toy, press the switch like this." Repeat the directions if your child does not ask for the toy within 5 to 10 seconds. Be positive with your child. After your child asks for the toy, offer praise like, "Good job asking," and give the toy back to your child to play with. Give a hug, a high five, or something else she may like. Show your child how happy you are with their good behavior. After your child asks for the toy, he or she may play with it for 2 minutes. Then you repeat the steps over and over for one practice session. Here are the steps to implementing FCT for a toy.
Okay, so that's just to review it. So now this is going back to our example for a child with escape maintained behavior. So the treatment plan looked a little bit different than what you just saw, but it's that same idea of a pretty targeted, tight treatment plan. And you can see here that on this graph, their problem behavior, so remember that was like aggression and self-injury and destruction of property, went down over time. Again, these sessions are like little 5 minutes a piece. And you can also see here that over time, as those behaviors went down, they added in more work that the child would have to do. More in terms of the demand. So it started with just one thing that the child had to do. I'm sorry, I don't know the demand on this one, but in the end, they got, it might have been cleaning up or something like that. They got up to 40 things that the child would have to do. And so, yes, again, you see some changes pretty quickly because you have that nice targeted treatment plan. Okay, so now I want to spend some time talking about parent-child interaction therapy. And the reason is because it's pretty popular here in Iowa. We have a psychologist in the Department of Psychiatry that's done a lot of training. This graph is a little out of date, but the number of therapists she's continued to train over time is quite impressive. And so we have PCIT in quite a few different communities here in Iowa. And it's a behavior therapy that's it's been around a long time, and it's another one of those ones like the one I've just been talking about where we involve parents in the therapies. It's parent mediated. So developed in the 70s and with ideas about balancing demands and being responsive as a parent, how to best give directions to your kid, how to use praise when they're compliant. This one does use timeout. So, you know, I just talked to you about timeout and being cautious about that with escape. And so that is one thing that people wonder about with PCIT and autism. Basically, the person who developed it, she has a lot of assessment, but the assessment is not focused on determining the function of the child's behavior. It's focused more on getting other information, both by observation and rating scale in terms of the behaviors the child is showing, the way parents give directions, how they play with their child, that sort of thing. And when you look at therapies for young kids across all kinds of childhood disorders, PCIT is near the top in terms of the amount of research that has been done, not for really any disorder. And particularly, you know, when you look at using this for treating young children with disruptive, dangerous, and destructive behavior, it does really, really well in terms of the intervention studies. So, you know, it starts out with basically teaching parents how to follow their child's lead and play in very specific ways, using these pride skills, and how to use selective attention, selective ignoring. Thinking about that idea of like, it's going to hit a little bit of everything in terms of function, because it's not something that takes a functional approach. So we're going to be doing lots of different kinds of behavioral things with the intervention like this. And so this assessment on PCIT, much shorter than a functional approach, much shorter than a standard functional analysis. But the treatment one might argue would be probably longer because you're throwing in a lot of things that maybe don't fit for this child's particular behavior. Okay. Second phase of PCIT, we work on effective directions and follow through. And I think I'll play a little bit of this video just so you can get a sense of what parent-child interaction therapy looks like. This is from a center in Michigan that does do a lot of PCIT with children on the autism spectrum. But I like this video because it shows kind of what the space looks like and what the setup looks like for the person doing the teaching and coaching, the therapist, when they're working with parents. So we'll go ahead and watch this for a couple minutes anyway, and then move on.
It's hard as a parent to see your kid struggling. We had been having some behavioral challenges with Gus, both in school and at home. And I felt a little bit helpless because I didn't know how to make that struggle easier for him. When we came to Sunfield the first time and we met with Susie, I remember at the end of the first visit, her saying, "I think we can help you."
I'm Dr. Susie Naguib. I'm the clinical director at Sunfield Center. As parents, we all want our children to be happy, to be confident, caring, and well-adjusted. Parent-child interaction therapy, or PCIT for short, is a treatment to help parents improve their relationship with their child while using positive parenting skills and effective disciplinary strategies, and helps children learn to follow directions in a predictable and nurturing environment. What's unique about PCIT is that parents practice new skills with their child while receiving live coaching through an earpiece from behind a one-way mirror.
Yes, that's exactly what you do.
PCIT is done in 2 treatment phases. The first phase involves teaching parents a set of positive parenting skills that have been proven to create a warm and secure parent-child relationship.
I like that you're being so creative and flexible with how you use the Legos.
The next phase of PCIT involves teaching parents how to give effective commands and use disciplinary strategies in a consistent and predictable way.
Please hand me 4 white blocks.
What we find is that as parents continue to practice, their skills improve, as does their child's behavior.
Once we started learning the method that Sunfield uses, we saw pretty immediate progress with Gus. We still had some challenges, but it felt like he was more in control, and our relationship with him just felt so much more positive. And that just made our home life almost immediately easier. One of the things that they ask us every week when we come is what percentage of directions is Gus following? When we first started coming here, 10% of the time. And now when we come most weeks, it's 100% of the time. It's a night and day difference between when we started.
PCIT is an evidence-based treatment. It has been heavily researched and found to be effective in helping families. Every family that completes treatment is considered a treatment success. Treatment ends when parents have perfected and mastered their skills, and the child's behavior has significantly improved. What is wonderful.
Okay, so I'm going to stop there. So that really gives you a little feel for what it looks like and how that setup looks like with the therapist doing some real-time coaching with the parent through that earpiece and through the one-way mirror, or sometimes there's a camera system to be able to work with the parent. Okay, so then people had the idea of like, hey, can we try out this therapy for children who have autism and comorbid dangers or disruptive behavior? So there was a lot of thoughts about why this would be a good idea. And so people tried it out, and then they started to establish a little bit of an evidence base too. So I'll quickly run through that. So the idea of why people thought it would be a good idea is because these pride skills have a lot of similarities to things that we use in developmental interventions, which are an emerging treatment, and naturalistic developmental behavioral interventions, which are a established treatment for autism spectrum disorder. There's lots of overlap there. And as I said at the beginning, children with autism are at increased risk for problem behavior. And in past webinars, we've talked about how there's increased likelihood of ADHD as well. And last week, we talked about how parent training is really an important piece of many evidence-based practices and has been incorporated into a lot of autism interventions here recently. And, like here in Iowa, I think it kind of goes back and forth because ABA has grown a lot as well. But there are some areas of the state where we have more PCIT availability than like ABA access. And so the idea of like having something in areas without autism services was very appealing. Okay. And there's been 3 published randomized trials from 3 different labs. So that's great to see. And they all show that it works well for treating some behavior. They all have slightly different results, but in general, they're all supportive. And there's also some single subject designs and case series data out there as well. So when we think about like evaluating the quality of the research and the amount of research, it looks good. Now, a lot of people do things a little bit differently than their standard PCIT when they're working with an autistic child. So they might use more visuals like visual schedules or visual labels. They may create a social narrative to help the child understand the expectations. And when they're working on compliance, they may work on different kinds of prompting beyond just verbal directions. Sometimes people, if they're concerned about escape maintain behavior, avoid timeout, or sometimes the chair doesn't work well for timeout, even if timeout is an appropriate consequence. And other people just do the first part of PCIT, and so that's an option as well. So even though there is a lot of PCIT out there, it's not like a cure-all. And so we got to be asking questions like, hey, maybe functional communication training actually would be the better way. How can we do this for this child? How can we get more people trained in this kind of behavioral approach? Or maybe we're using PCIT to try to work on play skills, but like maybe it may make more sense to do that through ABA or through an NDBI. And we also have to be really sensitive to whether a child can follow directions so they have enough understanding of language that makes sense as an approach. Or some people like think about this in terms of like working on social skills, but there's lots of good social skills programs out there. So I just want to kind of leave with like this cautionary statement of, though there is a lot of PCIT in Iowa, it may not be the best fit. And even in situations where, we're kind of using it to gap fill, we should still try to advocate for things that would be even better fits, but even a better fit for kids that are out there. There's been a lot of research, like I said, they even have a handbook that's covered all we know about using PCIT for children on the autism spectrum. And here in the last few minutes, I again want to leave enough time for questions here at the end, but let's talk just briefly about eating concerns. So when we think about kids coming in for treatment of eating concerns, tends to fall in 3 categories. First would be a skill deficit. So maybe like this is a child who was hospitalized for a long time and is off track from where we would think age-wise in terms of their development, and needs to develop the skills to be able to, for example, feed themselves. Maybe it's more of a preference issue. And this does come up oftentimes for children with autism, where they become very sensitive to how things look or taste or feel, or even like look in terms of like the brand, and so we can work on that as well. And then the third category is more behavioral issues, but kind of around meal times. So There's these ongoing environmental factors out there that we want to try to tighten up in terms of our antecedents and consequences. So thinking of like a child, for example, that isn't sitting at the table for very long, and that's a goal for the parent to be able for them to sit while they're eating. When thinking kind of about that middle category of like food preferences and things, there's kind of two different approaches. One is a more sensory approach. One is a more behavioral approach. They have kind of different theory behind them and different than theory that informs the treatment. The big thing I want to say is the behavioral approach has a lot of research evidence showing that it works well. The more sensory approach, and specifically the SOS approach, does not have a lot of research evidence for it. And so people taking more of that behavioral approach oftentimes think about how they're going to gradually increase the demand on the child. So whether it's targeting the environment or the foods, alternating things that are like challenging versus comfortable or preferred with less preferred, or how they're gradually maybe placing the food on the plate or near the lips or on the lips, on the tongue, taking an actual bite. But it's all done with kind of a gradual exposure in mind. I don't usually recommend specific books, but I just thought this was such a nice one because it is done by folks who are kind of the big folks in the field in terms of doing a more behavioral approach to treating eating preference concerns. But it's a book written for parents. Okay, so again, I kind of rolled through those last slides. If you want me to go back and talk about anything in more detail, or if you have questions, I'll take those now.
Please go ahead and type any questions you have in the question box, and we'll give people just a minute or two to get those in there. Hey, how do I find out if my son can do PCIT? I think it would help him and I a lot.
So if you want to look at kind of where providers are located in Iowa, people who have been trained through the University of Iowa, there's a website that's like PCIT Iowa.edu. That might not be quite right, but you can also just Google PCIT Iowa, and that website will definitely come up where it's listed by regions, people who have gone through training at University of Iowa. So there's kind of that step of like finding, do you have a person in your area? And then the second step is, I think, kind of talking through with that person if this makes sense versus something that's more of a functional approach to treating a problem behavior. I think particularly if there's something that's tangibly maintained or attention maintained, it makes a lot of sense to go forward with PCIT. And even in some instances, in terms of escape maintained behavior, it does as well. I think you just have to be a little bit more careful about how you approach PCIT and what kind of modifications you do.
The next question is, we had a young guy that would only eat sugar bars. We tried letting him help make stuff. He would just throw it. Any suggestions?
So, so I would think like if you really only is eating like one kind of food, that really is the time where you're probably going to need to work with a specialist to start to try some gradual exposure and some gradual tolerance of other foods. And again, first, it honestly can be just like on the table, on the plate, before they would try something in terms of like touching to the mouth or that kind of thing. But when it gets where kids get really, really narrow in terms of the number of foods they're eating, that's when it makes sense to me to make a referral to a feeding specialist.
Okay, we have one participant with their hand up. Tammy, did you want to ask a question, or feel free to type it in the question box? Another one came out. The participant said thank you for the answer. What about a child who does have some variety to foods but still will not try other foods?
So oftentimes, I mean, so that's usually not like necessarily a referral to like a feeding specialist, but something you might, if you are working therapeutically with like an autism specialist or a master's level therapist in a community health clinic, that should be kind of at a level where they could kind of help you think about how you would want to set those things up at home, or maybe even try out in the clinic. Again, the behavioral approaches are going to have more evidence. So things like stuff that would be in that broccoli boot camp book, I think would work very well in terms of trying to widen that exposure. There's another intervention I really like called, it doesn't have as much research behind it, but it is behavioral. It's called family mealtime coaching. It's out of one of the UC schools. I'm trying to remember now. I think maybe UCLA, but it may be somewhere in Southern California. And they also really try to emphasize having kids serve themselves. So serving things family style on the table. And so kids can take just a little bit of it versus a lot. And really trying to present a wide variety, many more times than you think you would need to. Like sometimes even like 15 or 20 times. So really giving it a very, very ample shot for a kid to try new foods.
Okay, a lot of questions about food today, and you answered part of this one already, but how do you get a child to talk?
So that goes back to talk for food, or just to talk generally?
I think this one's generally, and the other part of the question had been about food that you already answered.
Oh, okay. Yeah. So when we think about communication, we oftentimes think about the functions of communication. So like requesting is oftentimes an early communication function. So oftentimes we start there. And if a child isn't verbalizing a whole lot yet, we may work on gestures such as pointing. And we also may work on alternative communication, such as picture cards or this like switch that I showed today, those kinds of things. And people sometimes get concerned that like those gestures or those alternate communication systems, you know, if kids learn to use those, then they won't have a reason to talk verbally. But that is not what the research shows. The research shows kids are more likely to talk if they use those things early on. And so yeah, we really want to think about kind of a multimodal way about it. While at the same time trying to encourage verbalizations as well and reinforcing lots of word approximations.
Okay, well, we're out of time for today, so we will try to get to the rest of these questions and answer those for you, but we look forward to seeing everyone next week for our last session on educational programming. Thank you, Dr. Pelzel.
Thank you.